So we will open the session. It's a live case session for CTO PCI. And my co-chair, Dr. Asakura, is also joining. So, and we have a great faculty here with Dr. Haraba, Dr. Ashida, Dr. Masaaki, Dr. Feng, Dr. Kyu, Dr. Lee, Dr. Natalia Pillai, Dr. Okutsu, Dr. Simon Walsh, and Dr. Yu. So the first case is basically from Japan, from the Mia Heart Center, and we have a case as well from Seoul, from the Severance Hospital. So we'll start with the case from Japan with Dr. Kinja Nasu. And Kinja, I hope you can hear us, and it would be great if you can introduce us the case.
Okay, can you hear me?
Yes.
Yes, we can.
Okay, so good afternoon, everyone. So I show my case. So my case is a 70s male LAD CTO case. So the patient has a chest pain on effort from the beginning of this year, and he received a coronary angiogram in last month. So he doesn't have a history of the myocardial infarction and any interventional procedure. Next, please. So as coronary risk factors, he has a diabetes, hypertension, and hyperlipidemia. EGFR a little bit down at 50.2. Next, please. So the echocardiography ejection fraction is maintained, and but treatment test is positive. So we decided to treat this LAD CDO. So we're gonna share the angiogram. 字になびに書いて。So you can see the next piece. 一番違い、一番。So this is a recorder view. So entry point is almost overlapped at the diagonal. Next piece. So this case is also the entry point is overlapped at the first diagonal. But you can see the occlusion is started from the middle of the LAD. Next, please. So this is areocranial view. So you can clearly see the CTO is started from the just distal diagonal branch. Probably we can see some stumps. And next, please. Okay, next, please. Right, in terms of the collateral source, there is some septal channels. Next, please. And also some collateral from the conus branch. But it's not so clear, right? Next, please. This is areocoda view. So you can see some septal connection to the LAD. Next, please. Okay, light is okay. So, back to today's shot. 今日の暗示にも So anyway, I want to check the collateral channel from the conus branch because sometimes it's very clear images around the distal landing zone, this kind of the chip injection. But it's not so clear. So I decided to get the bilateral shot. Next, please. But the bilateral shot is not so, you cannot see, not so clear that the distal landing zone. So could you share the CT angiogram? No, today? So CT をシェアできないですか?
So
Anyway, yes, please.
Kenja, maybe there might be also some disease on the distal cap. I'm not sure. Now we see the CT. Probably you could explain us a little bit what you're seeing.
Yes. So the CTO itself is very short from the CT findings, but the collateral image is not so good. So that is my current situation. So could you discuss about this case?
Sure. So basically, I think the antegrade takeoff is, I think you visualized it very nicely, but agree that the distal landing zone might be not so nicely seen as you described. Might be multiple sources of collaterals. Definitely the conus branch has a source to the distal cap. And nevertheless, I mean, once you do the great antegrade puncture, probably intraplaque tracking is quite a high chance for intraplaque tracking to get the wire down. So, and I think even if you end up somewhere in the vessel architecture, you have still beautiful retrograde options as well. So I think it's a very, very nice case to demonstrate the beautiness of CTO PCI. Could you probably tell us what you have done so far before we start the discussion in between us? Kenja?
Yes.
Could you just tell us what you have done so far before we start?
No, nothing to do that.
Nothing. Okay.
I inserted the wire to the diagonal so that I put the Sasuke to the LED and just started the LED wiring from the antegrade side.
Okay. All right. So, Dr. Asakura, what would be your primary strategy here? Would you do an IVUS-controlled puncture of the cap? Do you think it's important if we don't have good visibility of the distal target and there's no calcification that the IVUS-controlled antegrade puncture of the cap could increase the intraplaque position of the primary wire and has a very good success chance in this case?
Yeah, I totally agree with you. First of all, I'd like to introduce the IVUS catheter into diagonal branch.
Yeah.
And then,
Okay. Kambis, I'm sorry. I did the IVUS from the diagonal side, so I will show the IVUS.
Oh, that's good. Yeah.
Okay.
That brings us further.
I'm sorry. So this is ちょっとそれそんなもうちょっとそんな So yes, this is the IVUS in the diagonal. So maybe in the 2 o'clock, you can see the LED. But I think that there's some stumps. And also, the CTO is not beginning of the just distal the diagonal. That means that it's not the no stump CTO. Okay? もうちょっとその辺よく見せてあげて。
So it seems to be no really big calcified plaque there for the puncturing, right? So,
No.
Simon, is it useful? Is it helpful for you, the IVUS here?
I think generally yes, but in this case it's not adding an awful lot because we don't see the true cap. But I do believe there's a significant value for sure in IVUS guided proximal cap identification. People, when they're beginning to learn it, struggle a little bit to get the hang of it. I think the key thing is that as long as you've got a side branch, it doesn't need to be very big, you can do a pullback, and what you'll see typically is a small, healthy side branch, maybe 2.0 in diameter, and then you'll get a sudden jump in the diameter of the whole vessel, and usually the entry point to the CTO is visible at that point, and that's typically where it is. So it's just getting yourself used to that pattern recognition. And if you can, if you have a scenario where you're struggling to understand if you're in the target vessel or whatever, actually if you leave the IVUS in there and you move it up and down, you can track the equipment into the CTO, and you can be very reassured that you're where you want to be. So it adds a level of safety, I think, for sure.
Dr. Asakura, I've seen many cases of you. You like to work with the 8 French, and do you do the simultaneous puncture? I mean, with the IVUS inside and then puncture, and you also observe your puncture point, or are you only detecting with the IVUS the proximal cap and then retrieving the IVUS? So always recommendation of simultaneous puncture with the IVUS inside or not?
In Japan, 7 French catheter is available from radial artery. So one side I choose radial, and another side will be femoral, 8 French.
8 French, yeah.
Yeah, I think the combination, I know the Asian patients are different, but certainly in Europe, you'll get 7 French in a radial pretty much all of the time. And if you've got a 7 French guide with a 5 French imaging system like Opticross, you can usually do that with a microcatheter. I think one watch out is that some of the guides have a smaller internal diameter than others, the Cordis in particular. So if you are using routinely Cordis guides, just be a little bit wary that some things might not fit that will in other combinations.
So maybe we can ask the panel as well. I mean, based on the IVUS image and which primary wire they would choose for the puncture. I mean, I know it's always the same questions, but nevertheless, it's interesting to see. So maybe we start at the left. Which wire would you take for the puncturing here? Dr. Ashida?
Yes.
Oh,
Yes.
right. Yeah,
So
sorry.
this CTO site is a very short region, but the distal target vessel is very small. It means so that to correct the puncture at the entry point is very important. So my plan is simultaneous IVUS checking, and Gaia next second or third I choice, and then wire step down after puncture. But IVUS reveals the entry point of CTO has vessel, blood flow. So it's more soft wire is maybe useful, but the proximal LED is large vessel, so I am afraid to prolapse the wire to prolapse to the diagonal branch. So I use the Gaia next second or third for the function wire.
So Kenja, are you happy with your puncture?
Yes.
Yes?
Yeah, now is I try to penetrate the proximal cap.
Okay.
I think the importance of the dual lumen catheter here is
But,
something not to miss.
I think
Because it provides a very stable platform to work from, and I think having a low threshold to use dual lumen catheters is better than having a high one, because it normally puts you into a very steady place to work from. So personally, I use them fairly liberally, and you, again, normally have a side branch at a CTO proximal cap. So I find them very helpful at this stage of the procedure.
So at the moment you have Sasuke, is that correct?
Yes.
And
Yes.
and which wire again?
This is a Gaia next one.
Gaia next one. Okay.
Asking CTO operators which one to take is like asking people their favorite beer.
Simon, could you, I mean, for us in Europe, it's a little bit new to work with the new Gaia Next. Did you have already the opportunity to work with?
I've
or
just
not?
got them, so I've
Not yet.
very little experience.
Yeah.
Defer to our Japanese colleagues. But I think, there's a dichotomy in terms of the first wire, which is, have you got some relative ambiguity of the course of the CTO, and is it longer, or is it short and very well-defined anatomy? If it's short and defined anatomy, I think, the Gaia Next type of wires, that's fine. If it's long and there's potential ambiguity, I think jacketed wires are less likely to exit. So there is a safety question between the two choices in those two buckets. So for long, potentially tortuous things, I would take a jacketed wire first. For short, defined anatomy, I think these directed penetration wires are fine.
2ちょうだい。おい、2ちょうだいって。
So, Dr. Simon, so which wire? So, polymer jacket wire. So, which one do you like? So, for the first wire for this situation.
I like Gladius. I think it's very steerable. I love the fact you've got an extra 30 centimeters of length for trapping and all of those other things. So,
Which one?
Gladius.
Claudius, yeah.
Oh, yeah. About just 3 gram.
Yep.
So now my Gaia Next one is very slip to diagonal side. So I changed to the Gaia Next 2, changed the direction.
And you need an additional bend, right? Because it's
Yes,
the
yes.
angle is quite. You have to puncture to 6 o'clock. And
Yes.
what I've seen, the Gaia wire, the first was going to 5 o'clock or 5:30 or 4, between 4 and 5 o'clock. You couldn't puncture down, right? And not,
Yeah.
directly.
Anyway, this case is a landing zone. The collateral image is very poor.
Yes.
So the one puncture, puncture twice, impossible. I quickly move to the red approach.
I think that the occurred the proximal cap site is very broad base, so I think that the exact center point penetration is very important for this case. I think.
Interesting once we're through and onto the later stages of the procedure, but I think a lot of LEDs that look like this have long courses of intramyocardial bridging.
Yeah.
And it's fundamentally important to image and to make sure that you understand if that's the case or not, because clearly you definitely don't want to stent into those segments, and the patient management, I think, should be dictated by what you find on intravascular imaging.
Well, I think it's very important to take here a little bit time for the antegrade cap puncture to do that properly, because it's really a great solution. Once you have, I think based on the CT scan, once you have a great puncture done antegradally, you might really have a good chance to get an intraplaque position there. And this is why he's also really taking his time doing a wire escalation technique, and not only try to get somewhere in the architecture, he really tries to puncture the cap somewhere in the intraplaque position. That's what I think what he's doing, and makes sense to me at the moment.
Yeah, and I think care and attention is important, because not everybody is a sensei, and those retrograde collaterals, sometimes they're less predictable, and we still fail to cross maybe 20% of them. So if we are meticulous about this sort of approach, if wiring is the most likely thing to be successful, I think we should be careful, take our time and make sure that we do it as well as we can, because whilst retrograde options may be there, it doesn't mean there's any guarantee you're actually going to cross them. So take your best bet and do it as meticulously as possible, I think, is the key.
The penetration power of the Gaia wire can be achieved only the wire is proceeded straightly, right, because of its characteristic structure. So in this case, we need to get a high angle to puncture the proximal cap. So personally, I would take Miracle 6, making big angle. And we can do the drilling technique to cross the proximal cap.
Very difficult. 자료 꽂았죠.
There's a lot of bending on the distal part of the wire somehow.
Yeah, I think the CT scan showed a lot of calcium right at that point as well. So.
Probably, yeah.
An interesting conversation is where your threshold to change. You know, maybe people in the panel, how much time do you sort of take before you think about retrograde here or an alternative approach?
Yeah, so but so this case is so one big issue is so retrograde. So distal target could not be so clearly confirmed. So that if guide wire integrate is so it failed, maybe so it's a time to change to the so retrograde procedure, I think.
And how do you make the choice? What?
At retrograde or
Yeah.
you mean
Is it time? Is it?
yes.
You know, what's the? It's kind of you get a sense when things won't go with it.
But so now so guide wire is looks
안 돼,
this, so if the, so this guide wire is completely so another way to the so distal target, it is time to change, I think. How do you think about the Kambis? It's time to the so change.
Well, you know, as more as I do, more I want to prepare anti-grade cap first somehow. So because anyway I have to do that. I don't see that direct retrograde crossing, especially on bifurcations, might work. But in general, I try to even if I go retrograde, I try to prepare anti-grade somehow to make my reverse card or whatever in the CTO segment and not at the bifurcation point. So I would take my time to penetrate that cap somehow. The decision is more how much time to try to get for the correct puncture or just getting in the architecture. And if it's possible to visualize on IVUS, I would take a little bit more time to visualize that correct intraplaque puncture with the IVUS. But otherwise, with these collateral options here, I would be also okay if I've just end up somewhere in the architecture and then go retrograde. I think there are quite good septal options as well.
Yeah, there's a few things go into the decision. There's the sense of futility that you can't get past a hurdle. And there's an experiential aspect to that. I think there's also how good are the collaterals or how good are the other options.
Exactly, yeah.
And if they're very unlikely to succeed, then you're going to persist for much longer with what you have. So it's a balance of a few different factors, I think. No right or wrong or magic answer to these things.
Yeah, I mean, once we have not that clear visuality on the landing zone, I think what we're probably not doing is to do a lot of parallel wire technique there, because that might really destroy the landing zone and visuality is going down, and then you might end up in a hematoma or something like that. That's if the landing zone is just a particular field. Whatever you do when you touch the landing zone, it might that flow is crashing, and then you think the CTO is more longer than it is, and you might end up in more hematoma there. So therefore, I think the threshold, if the collaterals are good, to change retrograde after getting an antigrade wire down is quite low. Oh, it looks good. He's checking on the IVUS and seems to be. Maybe you want to comment yourself. Are you okay with the puncture or not?
Puncture itself is there's some stump is there, so at least my wire direction is LED. But as Kambis said, the LED itself is very bended around there. But my wire is very easy to go to the diagonal side. So even though the guy next to is a direction, and changing the direction is not so easy. So at least entry is okay, but we
entry is okay, and then it's deviating almost, I think, not intraplaque, right? So I think it's end up somewhere in the subintimal space, basically.
Yes, sure.
It's hard to be
actually, even though the IVUS guidance, we cannot see the real entry point of this case, right?
Yeah, I think that's the struggle. It's hard to be 100% certain.
So I think it's time to the retrograde approach.
And then The other thing that may help here is to, once the wire extends a certain distance from the dual lumen catheter, is to actually switch to a microcatheter in the CTO body, which will give you more control over the guide wire as well.
Yeah, there's one comment from the auditorium.
Dear panelists, I would like to know, right, in this case, right, do you think that to take the advantage of Crusade Type R or Sasuke in this case, is there any difference between the type of DLC we are using in this case because of a bigger angle, or do you think it's not significant?
So the question is, when's a Sasuke useful versus when's a microcatheter useful?
I mean Crusade Type R. Crusade Type R versus Sasuke microcatheter DLC.
Yeah, I think if you've got the microcatheter close to the wire tip, you've got much better control and manipulation. So if the further the wire tip gets away from the exit point of the dual lumen catheter, the less supportive of an environment it becomes, and the less you're able to torque control. So we're probably at a point here where it's getting close to the trade-off of a microcatheter being a little more helpful just to get to the next point of the procedure.
Because some say that Crusade Type R have a more biggest angle, more compared to Sasuke, which narrower angle for the second port, exit port. So I wonder, would it be helpful? I mean, you know, when we went through training, they say that, you know, Crusade Type R, because of a wider angle, that is more suitable for bifurcation wiring. Do you think, is it make any significant difference in this case, or you think it's not at all? Thank you.
So that means so the difference of the Sasuke and between the double lumen catheter about between Sasuke and the Crusade R. So the angle of the side port. Yes, sometimes Sasuke is a little bit straighter compared to the Crusade R. So the angle of the side port is a Crusade R is a little bit larger. So that's for the puncture. So maybe so this is also some advantage to puncture, but also there is no evidence about consuming about that.
There's no evidence for a lot of these things. I don't have Crusade available to me, so.
Okay.
But I do think a standard microcatheter does become helpful at a point here, and
yes.
Maybe we're at that point.
Yeah, so like this situation, so the proximal site is a very large space, and from the large space to puncture is also very difficult. So that in this situation, so double lumen catheter has also big advantage to puncture.
If we can establish the retrograde routes of press wire, the wire can not only serve as a pacing wire, also can serve as a guide for the integrated puncture. So I think if we have a retrograde route, the successful rate will be higher. Maybe the wire can be an indicator for the integrated wire passing. So sometimes we may start the retrograde earlier preparation, not only by retrograde passing. Maybe the retrograde wire can serve as a guide for the integrated puncture.
So, Dr. Asakura, which is the easiest collateral? The conus one? Conus branch?
No,
looks easier.
Most of the time,
the length of penetration is too short. The conus is not a permission.
Bending angle is very acute.
Yeah.
And the length of penetration is very short. So it's not a promising one.
I mean, at home, I'm thinking putting a stingray about 10 millimeters down there and just re-entering, and not messing around with those collaterals if I don't have to.
Yeah.
So I do think that sort of equation is definitely a risk-benefit question, and ADR at the distal cap is going to leave you a very short subintimal course, has no adverse bearing on outcome provided you re-enter the vessel where it reconstitutes. So I think it's often a very good option in this type of scenario.
Yeah, I mean, here we have some great septal options, probably the safest opportunity to get the retrograde wire down. And as well, the conus branch doesn't help a lot because here it's ending up at the distal cap, so you can only get a wire down distally as a marker wire. So therefore, it's absolutely reasonable in terms of risk and also in terms for the CTO procedure to get this septal collateral wired. So at the moment you might have which wire? A Xeon wire?
Yes, Sean.
Xeon, okay. Xeon wire, Caravelle, and
Yes.
I think a problem we all face at the very early part of the RCA to LED collaterals is there's often quite significant tortuosity in the proximal part. I found the SUO to be helpful sometimes to get past that first little bit, and then you can switch to Xeon black or whatever you like.
So I want to check the chip injection again, a little bit more distal PD branch.
yeah, because I understand there are also some other branches who are giving collaterals to the septum. So great.
So there is some collateral.
Yeah.
Okay, we can try.
What the rest of the panel see, but it always seems to be that they come off the apex of the bend.
Yeah, there are some proximal ones coming up from the side branch, but what we don't see at the moment here, Kinja, is the uptake angle. So how are they really going into the septal? So sometimes it's not so easy to get that wired at the proximal. So the proximal part of those, or the first entry point. So we'll see how that works.
Yeah. I think there's no doubt that the more tortuosity the PDA has, the more challenging it becomes.
Exactly. It's always the same, right? It's easier from LAD down to because the tortuosity of those septal collaterals are almost at the PDA area and not at the septal takeoff. Yeah. So therefore, it's always a little bit more complicated to wire the septals from PDA towards LAD and LAD occlusions than compared to vice versa. Right?
Less predictable than we like to think.
Yeah. Sometimes they look very, very promising, but you just don't get the entry done, right? So might be also sometimes frustrating.
Or you can engage a little bit in the wire prolapses every time you try to go through with the microcatheter.
Yeah. So while he's wiring that, I want to ask you, Dr. Asakura, are you almost everybody's already uploaded with aspirin and clopidogrel in your cath lab when you do CTO PCI, or when do you give the dual platelet therapy?
Yes.
Completely uploaded, right? In all complex procedures or in all the PCIs?
Yeah.
All the PCIs.
사스케 줘야 돼? 예. 사스케잖아요. 수호. But actually, there is no promising channel is there, so that I will try to do one by one.
A broader question, is anybody working in a hospital that has something like Rampart or EGG or the more advanced radiation protection systems?
So I would like to get that from the beginning, but I couldn't explain to my administration the necessity of that because they are just counting euros and don't care, give a shit on how we are doing. So, maybe if I get serious problems, I can't work anymore, maybe the back would be an argument, but it's in their list of investment, it is something like maybe in 100 years you will get that. So I tried it multiple times. And I also tried to argue with Rampart, just give us this radiation protection for free. And it also didn't work because, you know, the plastic that you need every time is, I don't know, it's about, what was it? Was it 100 euro or 200 even?
I don't have it.
Multiplied by, you know, by 1,000 per procedure, or 100,000 by, so it has additional costs. Maybe it's only 10, even if it's only 10 euro, it will be like 2,000 procedures if you take it all the time. Yeah, but at the moment I didn't get the two parties together. So, but I would like to have Rampart, honestly.
I think it's an important conversation to have, and you know, there are a few options now, which is useful, and the expense between them is different. The egg nest, I think, is an interesting one. It actually goes holistically around the whole room, and it's about a 95% reduction in scatter with
it's impressive.
With the entire room involved. There's Protego, there's various other things. So, I think we need to collectively start pushing our organizations and hospitals and societies into taking the issue of radiation protection pretty seriously.
Yeah.
よし。これなんかもうちょっともう一個大きくしてくれない 4.5 インチに。した 4.5、4.2 でいい。ちょっとここだと分かんないんだな。クラリアでちょうだい。
It's difficult to understand the takeoff of the PDA collaterals here, and
it's just often the case, isn't it?
Yeah, absolutely.
So there's a small branch and there's so too many branch collaterals to the so in these situations it is sometimes very difficult to collect select the correct one.
Better, yeah, they're at least better. It's more caudal, I think, right?
Sure.
Oh, it's a cranial one. Sorry. Maybe the most distal one is also good, eh? Can you just the most distal, and it's also a strong one. I don't think it will rupture, huh?
Yeah, the proximal thing looks promising there. The one that's just off the screen.
1個前見して。
Those distal ones have also always a big bending, and therefore we are a little bit more conservative, but it's a strong one there. So I think it would be also possible.
I think the more proximal we go, sometimes you get too close to the cap, or you know, related to the CTO body. So you have to understand where the collateral is going to end as well.
おい、次見して。
This is a much better projection, right, Kenja?
Yes. Yeah, I think we can see the bifurcation.
Yeah.
But
I think the more proximal one, because the LED does extend very far up, so it's worth considering as well. We'll see how we go with these.
Yeah, maybe you are there. You were there. Okay.
これかな。これっぽいな。よし、これちょっと戻ろう。でもね。合わせて。
Yes. Okay. No, in a minute. So we go to the for the lecture now. Now to the lecture. Okay.
これじゃないんじゃないか。多分これが一番、分かった。こちらにあるし。
Okay, Kenja, we have to move on to your recorded lecture.
Yeah.
Even if you make here now great progress, I think at that point, once you pass the proximal part, or the first part, the wire will just, I think, hopefully easily advance, as we can see here. So based on the procedure, it's a very interesting point, but based on our time restriction, we have to unfortunately move on, and we will see your recorded lecture, Kinja. Thank you very much.
Yes, thank you very much.
So we move on to the recorded lecture.
Thank you, Chairman. So my lecture title is Novel Integrated Wiring for CTO PCI. So three-dimensional wire manipulation is needed to achieve wire crossing in the CTO region. When we advance the guide wire while changing the tip direction, guide wire track curve becomes a complicated three-dimensional curve with torsion, which makes guide wire behavior unpredictable and uncontrollable. There is a need for a novel wire manipulating method to overcome this difficulty. The principle of the penetration plane method is shown in this video, where the guide wire is manipulated on the single plane. Deflection occurs when the guide wire is advanced in the CTO without rotation. Unless the direction of the chip curve is deviated by torque, the wire orbit is always on the same plane, the plane formed by the chip and the shaft. The plane is a penetration plane. When approaching distal cap of the CTO for the penetration, the guide wire chip must always appear straight in the penetration plane view. Chip direction can be identified and controlled in the view perpendicular to OPPV is called the objective perpendicular view. Manipulating the wire is these two planes is the basis of the penetration plane method. The setting of the penetration plane view and objective perpendicular view as working view as in this slide. So we should always control the wire on the penetration plane. So PPV, penetration plane view, is a horizontal view of the penetration plane. And OPV, objective perpendicular view, is a vertical view of the penetration plane. I showed one case. This is a LED CTO like today's lifetime case. You can see almost a 2 centimeter CTO in the middle of the LED. This is a software to calculate the perpendicular angles, perpendicular projections like this. So after calculation, so we can calculate the vessel vector and two object perpendicular view, OPV and PPV. So for this case, areocranial and areocaudal is the projection on the perpendicular to plane. So after confirmation of the proximal cap with IBUS guidance penetration, so my guide wire, Gynex 4, is advanced gradually. So you can see my wire chip is almost touched to the cap. So however, from the only from the areocranial view, we cannot confirm the real wire position because angiographic view is a two-dimensional. So sometimes the wire chip is on the distal landing zone, but sometimes it's not. So when we advance its wire not on the distal landing zone, you can understand that our wire chip is very easy to advance to the subintimal space. So we should check the penetration plane view, the other perpendicular view. So in this view, you can see the wire chip is almost kissed to the distal landing zone. So I rotated the wire like a straight shape. And I checked in the OP plane again. So wire direction is to the distal landing zone. So I could push the wire and then getting the distal turbulent like this. You can see wire chip is almost distal landing zone. And we can check the other perpendicular view. So chip of the wire is also within the distal landing zone. So I can change the direction and make it a straight line in this view. So this is a penetration plane view. And then we check the wire direction again in the OPV. So now the wire chip is okay. So I push the guy next ball and get the distal landing zone. So this is the final result. Of course, this penetration method is very useful to use a plasma-mediated ablation system. So we already started the clinical trial in Japan, but we need the additional 2 years to launch it to the market. So in summary, penetration plane method is one of the strategies for antegrade re-entry at proximal or distal cap of the CTO. Detection of the perpendicular views is the first step. The calculation software will be released on the CTO club in June. So when a penetration plane method is used in clinical setting, one, PPV and OPV can be replaced according to the wire position. Number 2 is the guide wire always appears straight in the projection of final penetration plane view. And the direction of the guide wire chip must be confirmed in the projection of the final OPV before puncture. Thank you for your attention.
Great, thank you very much. So basically this perpendicular view, right, which is calculated by the CT up front, and then he has to give contralateral injection, and then it's calculated. It's a very interesting thing, but basically it's nothing else which was already solved, in my opinion, by the Stingray balloon. Because this is exactly what the Stingray gives us, is the perpendicular view. If you do a great prep, and you see the 2 layers of the Stingray balloon, and they're overlaying, you know where to puncture. There are 2 opportunities. And this is a great thing about that device, right? So, I mean, probably in future, I mean, at least when the machine can calculate that commercially, at least we know where to puncture in which direction. And I think basically what will be the end is on a certain point that we will have a computer, let's say a robotic, right? It's maybe the beginning of a robotic re-entry with CTO PCI, if we can absolutely just direct the wire inwards the perpendicular view towards the target and just puncture in. So that's the whole idea behind it. Just to explain a little bit more to the auditorium why this development process is done. It's well.
Yeah, it's elegant, but it's an awful lot of radiation. It's slow. The commercial viability of it, I would question, and the rollout ability of it, I think, is going to take a very, very long time. But I think IBIS is actually a better solution to give you an immediate answer that you can see. And is much easier to understand. So I think that's probably a pathway that's likely to get us to a slightly better place. But, you know, as you point out, Kambis, the Stingray option tells you 99% of the time. And I think with Stingray, you know, the thought process about long dissections and distal re-entries, that's all gone. What you want to do is get yourself as close to the lumen as possible. If you're not in, re-enter at the distal cap, and that's a very successful procedure. It's got an 80 to 90% success rate if you do it like that.
I mean, at the moment, what's still, I think, still complex for especially operators who are doing a lot of IVUS-controlled re-entry, I think is still the orientation, right, of the tip detection and then the puncture, right? So maybe a combination would be great to have a kind of Stingray with an IVUS where you have an idea where to puncture and also have a perpendicular view where you know where exactly to puncture, and then just visualize your puncture and confirm that you're and I think technically it's also feasible, right, to develop such a product.
Yep, it just takes a few $1 million.
All right, I think we have to go on because the Severance hospital is already waiting with my friend Byeong-Keuk Kim. And yeah, we'll see which case they have for us.
Okay, can you hear me?
Hello, yes, good afternoon.
Yes,
we
can you hear me? Yes,
hear you,
so good to see you.
and are happy
Yeah,
to
so
have you.
Okay. So good afternoon, everyone. So this is the Yonsei classroom. So welcome to the classroom, our case. So today is the RCA CTO case. It's quite a long time to see you again. And then the moderator is Dr. Kambis, and it's a really great honor to perform the live demonstration. So today I am Byeong-Keuk Kim. The second operator is Professor Yongjun Lee, and third operator is my two fellows. So Dr. Lee, could you show us today's RCA CTO case?
Yes, sir. Next slide, please. So our patient is 73-year-old male who came to our hospital due to the clinical presentation of the stable coronary artery disease. He had been diagnosed coronary artery disease, vessels disease, including CTO. We have already treated the left coronary artery. We'll show you the coronary images after that. And on the echo, there was a regional wall motion of normality noted at the RCA territory. The ejection fraction was okay, about 59%. Next slide, please. So this is the initial angio. We took the right coronary angio first. As you can see, we could highly suspect the CTO lesion starting from the proximal RCA. It looks very severe stenosis, including CTO. Next slide, please. As I told before, he had 3 vessel diagnoses. So for the LAD, there was a diffuse significant stenosis starting from the proximal to distal LAD. And also we could see the good collaterals, including septal and the distal LAD. But among them, the septal, the collateral 6 looks much better. And septal collateral, the size of the collateral was good, but however, it was very tortuous, including like 2 kind of tortuous branches. Next slide, and this is the caudal image. I think the next left slide I'm moving. We could see the weak collateral going from the distal circumflex too. However, as you can see, the right LAO caudal image, you can see the septal, the collateral is the most promising one. However, it's very tortuous, so we have to think about that. Next slide, please. And for the LAD, we have treated for it first. We used the 2 stent for 3.0, 3.5, and as you can see in the right side, the result was very promising. Next slide, please. And for the circumflex artery, we have to use the supporting catheter for including XDR. However, the result was good. We put the 2.5 stent, and the result was good. Next slide, please. And as I told you before, this is the CTO we are trying to treat today, RCA CTO, and the good collateral from the LAD, which is the septal branch. However, size was good, but there was 2 tortuous things we have to consider. Next slide, please. And as you see, we know the benefit of the CT during the CTO intervention. So we took the CTO coronary CT. The CTO lesion was suspected about 21 millimeters, and the blue, the rectangle is the proximal lesion, and the red rectangle is the distal lesion. As you can see in the blue rectangle lesion, the rectangle things, we could see there was a calcium, but however, the extent was less than 50%. So we have to consider that when we are making plans for the CTO treatment. And distal lesion, there was no significant stenosis. However, as you can see, there was a calcium scatter all around throughout the CTO lesion. Next slide, please. And this is the matched image of the coronary CT and the coronary angio. As I told you before, blue rectangle is the proximal segment. You could see the calcium on the proximal lesion. However, it was accounted about less than 50%. This star is the red rectangle. There was no significant calcium. However, as you can see in the right coronary CT image, the calcium was scattered throughout the CTO lesion. Next slide, please. And this is the MPR image. As I told you, it's just the same thing. There was a calcium starting from the proximal scattered all around. The CTO length is suspected about 21 millimeter. Distal seems looking okay, but however, this was a CTO. We need the CT images for making plans.
Okay, this is the summary of our case. So as you can see, this CT analysis is quite similar of the real our centers performed in the CTO cases. Is from the matching view and also cross-sectional images, and also we performed the qualitative, quantitative CT analysis, especially for targeting classification. So based on the CT analysis, we decide which plan would be best and which access, blah, blah, blah. Anyways, based on the CT scan, so we had a plan for the CTO PCI. So is there some comment or questions or our CTO case?
Well, first of all, thanks for the great case introduction. And I think this patient clearly benefits from revascularization. This is the most important here in the free vessel disease. And as well, the RCA is quite a large RCA. So I think you have very good options, antegrade as well, retrograde for sure. I think the most important thing will be, as always, the antegrade cup to solve that issue, and then we'll see how the wire is going. So did you already puncture the antegrade cap?
Okay, so so originally this case is anyway 3 vessel disease, and then having the 2 CTO is circumflex and RCA. And so previously we already discussed the treatment of this patient with his family members. So they want to perform the PCI. So 1 year ago, so if we fail the LCX CTOs, I thought that this patient would be better for the CABG. But luckily, the LAD and circumflex is successfully treated. So the reason why we should select the case of the RCA CTO on these live cases. So Dr. Kambis mentioned, so from the RCA CT analysis and also the angiography, so we can, from the MPL images, so we saw so many classified spotty classification. However, cross-sectional images, the classification arc on the, not clear, but anyway, on the CT scan, the classification, some amount was not so severe, and also especially from the initials, the side branch with the stump, proximal stump area, the classification is from the analysis, the calcium contents are less than 50%, so it's a good candidate of the antegrade puncture. However, there was no stump, and also is just before near the proximal stump is a large, big side branch is exists. That is also one of the problem for the antegrade puncture. So can I show today's angiogram is a bilateral image? Okay. Yeah. So today's I prepared the case is a bifemoral with the 7-French guiding catheter. So can you see today's angiogram is yeah. So basically from the initial angiogram is we thought and also the CT scan, the CTO length was not so long. However, today's case is previously 3 stent is all patent. However, the CTO length was not so short. So what do you think? Today the angiogram. So originally I had a plan to do the antegrade.
Well, what I think is, I mean, as I know, you do almost all cases with IVUS. What's going on in the prox LED? So is there a little bit more stent compression? Is this a late recoil there, or because the stent looks a little bit, dog-boned?
proximal LED stand?
Yeah.
I think you're saying the circumflex stent on FAS and the LED stent behind it in the right-hand panel there.
Now maybe there's a lot of blackburn there as well, right? Because it looks like a little bit dog-boned there. Anyway, maybe plaque modification was not so easy there at that point with eccentric plaque. So I think you have regarding the CTO, you have a very good opportunity for the antegrade wire escalation, and even if that fails, the retrograde options are quite good. So the chance of get the CTO done is quite high. I think it's a very, very well chosen case because you have also very short time for the live transmission.
Okay, so based on that kind of situation, so we already studied our case, and also the already further a step is already has gone. So I will show you today's our procedure. So initially, I had some time. So before the antegrade approach, I just want to know today's septal collateral is surfing. So next slide. Yes. So as you can see, in the middle of the stand is a very big septal branch was noted, and also we can see some very good collateral. However, as we previously mentioned, so some 2 or 3 portions of the very banded portion was noted. So there would be anyway some kind of the hurdle. So after finishing you can see, so there is if we failed of the antegrade procedure, so we quickly change to the antegrade approach. So some 2 banded was very severe. Next one. Next. Okay. So this is so after starting the antegrade puncture, so I firstly wiring to the side branch, even with some stenosis was noted of the side branch. However, easily a wire was moved, and then we used the balloon anchoring is 2.0, and then we started antegrade puncture. So the initial wire is I started with the Gaia Next 2. So as from the IVAS images, the CT images, we can know some situation of the proximal stump. So I just imagined it's good. It's really enough. The Gaia Next 2, if failed, is a Next 3 or Concast would be better. So this is in the middle of the CTO. So the wire position a little bit downward, but anyway, still chance to go to the true lumen tracking. So it's okay.
Yeah, we can see.
And then clearly. Yeah, and then from and also from the previous CT MPL images, some connection between the main CTO and side branch there is just a straight way, so I can just advance of the Corsair Pro, and after that a little bit forwarded use antegrade wiring. So on the aerial image, and also so this our system is biplane system, so we can very easily check the aerial and aerial view simultaneously or consequently. And this is the contralateral injection. So it's quite good. Is the wire tip is a little bit avoided, but anyway, a chance to negotiate into the true lumen. Next one. So this is from these images. I advanced the wire a little bit further. However, some portion was not so good. So I just thought anyway some chance to relocate the wire position, and then a little bit retracted, and then advanced forwarded. So wire and then gently moved
Yeah,
into
nice.
the ideal plan. So, and we check the angiogram like this. Maybe the wires would be the true man. Next one. Next one. And then we change the wire into the conventional wire. This is the status of our procedure.
Ah, okay, so very nice already, the great passage with the wire. So you had a kind of redirect a little bit the wire tip at the distal cap, right? That was the important part here with the Gaia second next, correct?
Yeah, yeah, yeah.
And the microcatheter was easy to pass?
Yeah, so we already know that some classification exists. Is the reason why the anchor balloon was noted, and then with aid of the 2.0 is supporting catheter is Corsair Pro XS is very easily delivered to the end of the CTO.
Okay, and there was a tiny staining in the collateral. Do you think that we should treat that, or you can just leave it?
Maybe we can check again after finishing the RCA CTO. So if I had some time, so I had some surfing during the Nasu's case.
Sure.
However, some portion was damaged. Yes, but the patient's symptoms is no, and also the staining was not so severe. Anyways, to finish the procedure, I checked again the status of the collateral damage.
Yeah. So, okay, then now the next step will be the balloon angioplasty and the IVUS, right?
Okay, so we performed the Relay 2.0 balloons from the mid to distal. So, and then we performed the IVUS. Could you show the IVUS, Professor Lee?
So this is the IVUS image after the 2.0 balloon, and this is the distal RCA far beyond the CTO lesion. You can see that there was a plaque, but not that severe at the very distal. But as you come proximal, there was a plaque in here. And we just wait a moment, and you can see that there's a plaque in here also. You can see that although the CTO lesion was about 2 to 21 millimeter, there was a diffuse plaque burden all around the RCA. And this will be maybe the reference area. You can see the plaque, abundant plaque burden, and the distal reference would be 3.0, I suspected. And you can see this is not. We have not reached the CTO lesion yet, which coming proximal and proximal. But although this is beyond the CTO lesion, we think that we have to cover all this area. So we think that the length of the stent would be very longer than we had been expected. So I think this would be closer to the CTO lesion, maybe the distal lesion. We have already ballooned using 2.0 balloon. And this is the CTO lesion we are coming up. We can see the calcium, which was already noted during the CT exam. And we are coming to the proximal. And the proximal is much larger than we had been expecting. We could reach the 3.5 or things like that. And this is coming to the end.
So basically, you don't need any further balloon angioplasty before the stent, or
so already we performed the 2.0.
2.0, and Simon, would you still go, I mean, even if you have the IVUS image and you see everything is correct, would you still go with a bigger balloon or just go with the stent?
So I think, based on the IVUS images, the classification was not so severe, so I think it will be okay with just stent.
Just stent, right?
Yeah, I think it depends on the IVUS appearance, really. If you've got nodular calcium or other things that you want to consider modification of, then you should do that. I think if you're confident, based on the IVUS findings, that you're going to get good stent expansion, then that's a reasonable step to take without anything more in terms of more aggressive or advanced preparation. I don't see any red flags here.
Okay, so anyways, we already prepared the stent DS is a long DS 3.0 46 to create. So if there was some some difficulty in the crossing the region, so we should again of the further treatment or not. Anyway, I will show you the our stand passing. What do you think the size of the stand?
I think the stent diameter should be predicted by your landing zone diameter, and you want to match the diameter of the stent to whatever the thing is distally, and then you can always post-dilate the proximal stuff into a bigger diameter with your NC balloon. So it's nice whenever you find your landing zone with IVUS to actually take a little puff and a fluoroscopic store, and then you can use that as a reference image to sight the distal edge of the stent in an area hopefully where there's a small or minimal plaque burden, and then you can post-dilate according to what the proximal vessel looks like.
Well, I think you should be able to put a 3-0 and then probably post-dilate.
Yeah.
Which stent do you have? Which size?
3.0, 46.
Yeah,
4. 조금 더 6. 6.
We rarely see 3.0 arteries in our patient collective on the RCA, right? You see, that's basically something that you sometimes cannot see in IVUS, right? Here, you see that particular. But anyway, even if you see it, I mean, what can you do, right? If it's correct, it's correct. You can do post-dial. And there's no, I mean, there's no difference in pre-dial or post-dial here, right?
Yeah,
With
well,
this,
I think if you've eccentric or nodular calcium, I would have a relatively low threshold to consider atherectomy for nodules. I think it's probably the most likely thing to modify them properly. This is maybe just a lower pressure balloon expansion that's not popping that lesion. And I'm sure an NC will do the thing. I think the key thing is to understand the IVUS before you commit to the stent, because when the stent's there, it's too late. So you need to be certain of what you're dealing with before you put the stent in. That's the most important message. And that's that little area of eccentric calcification.
But are you sure that that you always get the with atherectomy that you really get destroyed? I mean, you have wire bias, right? You probably would need a really large burr to get that modified.
It depends.
Right?
I think sometimes we think about that a little bit wrongly. I actually think that the degree of protrusion is probably a more relevant aspect in the nodules, rather than just where the wire bias is to or the IVUS catheter goes to. So often you'll see the nodule so protrusive that it'll touch the IVUS catheter even if it's on the opposite side of the vessel. And I think in those circumstances, atherectomy will still do something useful.
I mean, Simon, one important, I think, new development will be the backward, right? The double coin.
Bidirectional, yeah.
So when you can rotoblade backwards as well, right?
Inner surface, yeah.
And then you can more cut the inner surf. Here it would be perfect, right?
Yeah, certainly for those eccentric nodules that are on the unfavorable surface. The classic one being the distal left main, where it tends to have plaque formation on the outer side and carinal sparing. So when you're going into the circ, the burr tends to go towards the carina, and then if you have diamonds on the back, you'll get the inner surface as you retract and ablate coming backwards. Yeah, I would love to have that tomorrow, but it's going to take a while for it to get into clinical practice.
So okay, this is the implant of the this mid RCA stenting with the 3.0. So already actually I did not want to the distal edge damage. So the distal portion was under expanded pressure is under nominal pressure, and then I increased some pressure up to the 16. And then this is the 3.0. So maybe one more integrate a little bit a larger stent, one more implanted. After that, we evaluate again of the distal RCA portion. So what do you think, Kambis?
Yeah, as well. Probably here I would put another probably 3.5 stent. I don't know, but proximal maybe 16 or something millimeters or 20. And distally, I don't think that this is a real disease. Seems to be spastic, or maybe what I do in my practice is that I go down with a balloon and just do a 2 or 4 bar atmosphere. But if you have the IVUS there, and there is no disease, you might do nothing, right?
Yeah. But the pre-procedure IVUS images, already we know that some diseased portions noted in the distal RCA. So sometimes TB is sometimes helpful, but so what do you think in this situation?
Yeah,
is some always perform the TB or not?
Yeah, so if there's plaque there, honestly, so we do a lot of drug-eluting balloon there nowadays.
Okay.
Yeah, I mean, a couple of comments.
You know, because if it's soft plaque, Simon, and it works perfectly. What I don't know if it also works with a normal balloon, conventional balloon, but TCB works.
I think it's important that we measure for distal stent landing zone diameter, post-dilation, and also the proximal as well, and that we assimilate the information that the IVUS has given us and make sensible choices from it. So measuring rather than, because we've done a long pullback, we've got good information there, and we should make decisions based on measurement in terms of stents and post-dilation. The DCB question's an interesting one. I'm same as yourself, Kambis. I would use a lot for distal runoff, especially if it's not calcified plaque. The question is, are we treating the angiogram or we're treating ourselves? And if you re-examine this vessel in a period of time, does it remodel, and what is the actual clinical outcome from that? And I think that's something that we really need good trial-based information on. Paul Knappen is running the trial in Amsterdam at the moment, and hopefully we'll get useful information from that. But it's a pilot study, so it may lead us on to further examinations of the question. If you've got TIMI3 outflow, multiple branches, and things look moderate by IVUS, I think it's reasonable to stop. If it appears flow limiting, then reasonable to treat. But I think in terms of actually evidence-based answer, I'm not sure that we really have one.
Hi, Dr. Kim.
Yeah, agree.
How would you protect the side branch? Have you already done a balloon angioplasty to ostium of the side branch?
No.
Just the wire protection is enough?
No. So maybe the previous anchor balloonings, a little bit side branch is dilated. Very minimal pressure. About 2 or 3. So is it required to the protect of this side branch? Dr. Han?
Probably because it has a very severe stenosis, and I would place the microcaster to protect the side branch, or to bigger size of ballooning, probably. It's my personal opinion.
Okay. So this angle and also some calcifications. So I do not want the wire jailing. And also I want to remove the side branch wire before stenting. Is okay? Okay. And then we check the side branch is okay or not. Sometimes create balloon is we can see some. You can see some dot, so it's quite helpful. 12, 14, 14, especially perform the long stenting.
Dr. King?
Yep.
Excuse me, this is Dr. Go speaking from Taiwan. Did you consider gel balloon technique in important side branch to protect the side branch? Because we know that from the published data, gel wire is not so good as a gel balloon technique in protecting the side branch. If you meet the major side branch, will you consider the gel balloon technique to protect the side branch?
Yeah, so especially in the case of the CTOs, we already have the Corsair. So we had so many experience of the jailed Corsair protect the side branch. Sometimes it's helpful. Also, especially and also the jailed balloon is quite important. But I think this patient would be okay. So I checked the NGO.
Ready?
Mm-hmm. IVUS.
I mean, what you said is regarding. Sometimes we're just treating the angiogram. We really have to think about that. So I'm really looking now about IVUS because I didn't get that before. Because what we try to avoid is that we just go in with a balloon, then we might have an end-edge dissection there, right? For nothing, and probably there is no need for. And then you have another, let's say, 26, 24 millimeter stent length. And flow is good, so let's see what IVUS is showing. If there's some soft plaque and the plaque burden is not more than 50%, probably we can just leave it.
Yeah, I think these vessels do remodel as well. And if you bring them back and do follow-up angiography at 2 to 3 months, you get growth of what was moderate plaque and becomes less significant. I think there's a few questions here with the IVUS now. How's our stent expansion? There looks to be a wee bit of moderate under-expansion at eccentric calcium in the mid-vessel. And are we taking off our ultimate parameters? That's still the goal with CTO PCI. I think the one caveat is if you have subintimal segments, that you do treat those differently in terms of the post-dilation. So if you've got a relatively eccentrically expanded stent, that's okay as long as the area is good and you've got TIMI3 outflow. So 5.5 millimeters squared rather than going crazy in subintimal segments is adequate. The side branch here, we can see impaired flow at this stage. Sometimes a bit of nitrate helps. So it'd be interesting to see if we need to float a wire back in there and give it a squeeze with something small.
Okay, so this is the angiogram of the after stenting. This distal edge portion is quite good, and also the stent expansion is not so bad in this portion. And then previously, this is non-CTO segment is, as previous told you, is a whole diseased area. So we should discuss if we treat this portion or not. But in my opinion, is a whole disease segment, and also so there was a no flow limitation. But sometimes it's good, and also on the follow angiogram, so we will helpful to decide treat the distal RCA. Sometimes we also data of the distal vessel expansion was noted sometimes, and also really, not sometimes, really more than half cases, especially the proximal CTO is more frequently distal expansion occurs. So based on the follow angiograms, the further treatment sometimes would be better of the okay. So maybe in the middle portion, the previous first stent was on the expanded portions. Could you check the area of the MSA?
So would you do some additional NC, exactly NC balloon dilatation? That's what you're now thinking, right?
Yeah.
I agree.
Mm-hmm. Right.
Probably
right.
I would do.
Yeah, I think this reinforces the need that we really, I think, do gain useful information by a one-to-one size pre-dilation ahead of stent implantation. Even though there was nothing immediately obvious in that IVUS, it told us that region was going to be the thing that had the relative under-expansion of the stent. If we'd have taken a 3.0 long NC balloon and we'd seen that we didn't have full inflation, it offers you the opportunity to then make a different decision, cutting balloon, whatever is appropriate for the lesion that you're faced with. And I think that information is something that is very useful. And the other question here is, what's the true plaque burden at the distal edge? And I think it's just landed on a bit of atheroma, but it's not terrible. And again, the key thing is that we measure these things and actually make objective decisions rather than just throwing a sort of an eyeball at it. It's got to be better than that.
Simon, what do you think this is the distal portion treatment?
Can I sit on the fence?
In your usual case?
Yeah, I think there's distal diffuse plaque. I think where the stent has landed is probably okay. It's got a big area. There's a moderate plaque burden that's probably worth measuring. But there's such a short segment of it that I think chasing the stent edge itself isn't necessary, but then the distal disease is at least moderate for sure. But I suspect if you put the IVUS right out to the distal vessels, you're going to see plaque all over the place here, so you can't chase it forever.
Honestly, I mean, the stent was landed in a very healthy segment, and distal there's some plaque. I don't think that if you bring the patient back that in FFR this is positive. I think you can just leave it.
Yeah, I think you can also see how the patient does symptomatically.
Yeah.
And if the patient's doing well symptomatically, you don't have to chase after these things.
So how much pressure do you need here, or how much pressure do you have at the point?
Okay, so actually the entry balloon size was 3.0. So actually the portion of the 3.5 proximal stent, usually the area is okay. So as you can see, this is the 3.0 and also the previously classified region. So anyways, after checking the full pressure of the post dilation, so in now is the pressure is about 18 and 20.
18, 20.
22.
Yeah, I think a good rule of thumb here is that more pressure at the same size is better than bigger and bigger. That's when you get into trouble with the risk of perforation.
20, 24.
Yeah, we have still 3 minutes to go, and probably we can give some nitrates and then check how the distality looks like.
Okay. MTG. Kole. 18, 24, 26, 26. Okay, nitro.
Any further comments, Dr. Asakura, regarding the distal part? Would you put another stent or not?
트레이너 뷰 조금 줄까요?
It's a very difficult question, but I think this result is acceptable.
Just interested, I think a couple of the images there, I think the guide on the left wasn't quite engaged, the microcatheters there. I think there's a little bit of plaque at the ostium of the main stem, so it's worth paying attention to that before bringing everything out of the left side as well.
Okay. So I will check again the mid
I think it's a great
portion.
result.
Yeah. So the distal RCA is it's in my opinion it's better to see, and also we will decide after the follow-up angiogram. What do you think?
I don't think it's relevant. I know it looks more beautiful when you put a stent, but it's not relevant, in my opinion.
Right.
I think you could chase that from here to the end of the rainbow and not make this beautiful. You could use DCB. You know, I think we're in a happy enough position. The side branch, interestingly, still has slightly reduced flow. I don't know if anybody would chase after that or not.
So I want to see the IVUS image. So yeah.
Okay.
Okay.
Yeah.
Okay, then final IVUS, and then we go to the talk.
Okay.
So this is the IVUS, right? Distal.
Distal.
It's around 50% or approximately plaque burden, not more. And the stand is landing beautifully in a disease-free era, almost.
Right, this is the distal landing zone.
Could even postulate the stand more, but.
And maybe the previous MSA portion approaching. Highly expanded comparing the previous one. And more concentric.
Comes now.
Yeah.
Comes now.
This is the
this is the part. Probably not too much more, but probably a little bit. It's very difficult, right, to get that even more expanded now. I mean.
Right. So, but I think there was no major side branch in this area. So, in this situation, usually I increase the pressure more increased. So maybe the area is about 5 or 50 or something. So okay. So a little bit more dilate the middle portion. So could you check the MSA area?
And I don't know if it's an option in every country, but the OPN balloon can sometimes resolve these sorts of segments. But again, you don't upsize it. One thing with OPN, just to be wary of if you are using them, is that with dual core wires, at very high pressure, it can grip onto the wire and pull it out. So sometimes worth putting down some old technology just for the OPN dilation.
So area maybe the 5.3 something.
So in Japan,
you gained a little bit more, 0.7.
Habara, what do you think?
I think it's definitely more. It's I think I remember it was 4.4, right? Visually, from the visibility as well. So from the visual aspect as well. But I don't think you can achieve really much more there. Probably I would leave that, because if you go now with 3.5, might even rupture on the other side. So. And the distal, well, I mean, I took my decision for the distal part, but I think if you ask the audience, it will be 50-50 probably, I don't know, but also the panel, I'm not sure. I think it's quite a big diversity to treat or not to treat that distal lesion. And this is a 3.5 or what is it?
20. 3.0.
3.0. All right.
22.
Okay, Byeong-Keuk Kim, unfortunately, we have to move on with your recorded case, and thanks very much for these beautiful images and IVAS images and CT images today. And you see, there is a lot of discussion still going on, and a lot of things still to be studied as well, and to be also, we need also a little bit more data regarding distal bend in CTO. And we'll now go on to your recorded talk. Thank you very much.
Okay, thank you, Kambis. Yeah. Thank you.
Okay, I am Byeong-Keuk Kim from Yonsei University Severance Hospital. Today, I would like to talk about the pre-procedure CT planning for the CTO success. This is my disclosure. One of the effective methods for the improvement of the rate of the successful CTO canalization is the CT scanning and analysis before CTO procedure. What about the role of CT scan in CTO PCI? Coronary CT scan could identify CTO as a diagnostic tool, predicting a clinical benefit from the CTO PCI and procedural outcome of PCI, and help to make a plan for the CTO success, and could visualize CTO segment, and could be used as the long-term follow-up for stent patents. The CT scan is essential for making a primary and secondary pro-procedure plan with assessment of the risk and benefit of the procedure. When you look at the result of the CT-CTO randomized trial, which is mainly conducted at Korean CTO Center, and evaluate the effective of the pre-procedural CT scan on procedure success by a random comparison between CT-guided CTO versus conventional angiography-guided CTO PCI. A total of the 400 patients were enrolled and success rate was compared. Hypothesis of the CTO trial was the success rate of the CT-guided CTO PCI would be superior to the conventional angiography-guided. Primary endpoint was the rate of the successful recanalization. So as compared to the conventional angiography guidance, pre-procedural CT guidance for CTO resulted in a significant higher success rate, especially higher success rate more prominently observed in patients with a high CTO score is a difficult CTO than those who did not. So for this CTO or PCI for CT-guided CTO PCI, we made the two orthogonal CT image matching with angiogram. By this, we could understand CTO course, how CTO course goes, and what the hidden root is within the CTO segment, and anatomical location associated with side branch. To quantify the degree of calcification, the cross-sectional and longitudinal calcification evaluation were performed. In addition, analysis of the segment around CTO was performed, including the check of the vessel and lumen size. For the CT-guided CTO group, first we made two orthogonal CT imagery, 3D volume rendering imagery, and MPL image corresponding to two orthogonal invasive angiography. By this, we could understand CTO course, how CTO course goes, and what the hidden root is within the CTO segment, and the anatomical location associated with the side branch. Second, the assessment longitudinal and cross-sectional image is post-procedural SINS lab and MPL image was performed. Longitudinal and cross-sectional images were visualized to assess CTO length, CTO plaque characteristics, and the amount and distribution of calcification. To quantify the degree of calcification, the cross-sectional and longitudinal calcification evaluation were performed. In addition, the analysis of the segment around the CTO were performed, including the check of the vessel and lumen size. So this involved both qualitative and quantitative analysis of calcification. First, a quantitative calcification analysis were conducted by the dividing CTO segment into the three portions: the body, proximal segment, and distal segment. Subsequently, the arc of cross-sectional calcification was assessed along with determination of the presence or absence of the cross-section with maximum calcification extent greater than 50%, and the length of calcification with maximum calcification greater than 50%. Furthermore, the shape of the proximal and distal CTO end was evaluated as either blunt or sharp. Additionally, reference vessel diameter were measured on the cross-sectional image. This is the report form of the CTA analysis for CTA guidance. When you look at the subgroup analysis of the CTCTO trial, the impact of pre-procedural CCTA on success rate was consistent across the subset, except for the JCTO score. The success rate for patients with a JCTO score greater than 2 were significantly higher CCTA guided than in the angiography guided group with a significant interaction. In case of the blunt stump or long torture CTO, the exact location and the course of the CTO would be essential for wire crossing. Pre-procedure CCTA could show the exact anatomical location related with adjacent side branch and the course from the proximal to distal CTO cap. We review the MPL image. Initial wire direction is like this. However, we changed the wire direction, targeting opposite side of the side branch, not to a side branch side. Finally, we made the parallel plan of the both wire. In case of CTO, with severe calcification, CCTA visualizing the CTO course and plaque characteristics could be helpful for the navigating and the selection of the proper antegrade and retrograde wire and device without increasing risk of the procedure complication. In case, especially in case of the reattempted case, is a CTO PCI after previous failure, the CTO success could be improved by adopting the strategy for reattempt based on the various information from the longitudinal and cross-sectional result of the CCTA analysis. When you look at the analysis regarding the reason for CTO failure of antegrade only approach, failure to enter the cap due to the anatomical ambiguity is more frequently occurred in the angiographic guidance. In the analysis, failure reason of a hybrid approach, including the retrograde PCI, most regional failure in the CT group was the failure to cross collateral with a retrograde wire. There was no case with failure to enter distal cap with a retrograde wire to deliver the supporting catheter to meet both wire or to achieve team grade flow greater than 2 after stenting. Although there was no significant difference of the procedure and crossing time, antegrade only crossing time was significantly shorter in the CT guided group. In addition, CCTA guidance group compared to the angio guided group showed a significant higher rate in the retrograde CTO attempt. CCTA may be used to visualize the CTO course and plaque characteristics. Interestingly, CT-guided CTO group showed a trend toward having a lower rate of the coronary perforation during CTO procedure. So the rate of emergence procedure or surgery were not significantly different. Similar trend was noted in the occurrence of large peri-procedure MI, relatively low rate in the CT-guided group. Ladies and gentlemen, this is my take-home message. CCTA guided CTO PCI based on the pre-procedure CT planning resulted in a higher rate of the successful recanalization, especially the difficult CTO is a JCTO score greater than 2, with a lower trend of the complication, especially coronary perforation or large peri-procedure MI, and a high efficiency, less time in the antegrade CTO, and high success rate in retrograde CTO during CTO procedure. A thorough understanding of the CCTA image, CTO course, anatomical location, and calcification analysis will help us to make a CTO success, especially in difficult CTO. Thank you for your attention.
Well, thank you very much. Unfortunately, to the sake of time, we have no time for discussion left. I want to thank my co-chair and the panel for this session and wish you a very nice Congress. Thank you very much.